Welcome to GW Integrative Medicine, the podcast about disease prevention and health promotion from the Office of Integrative Medicine and Health at the George Washington University School of Medicine and Health Sciences.
I'm your co-host, Dr. Mikhail Kogan, Chief Medical Officer of the GW Center for Integrative Medicine, Associate Professor of Medicine here at GW, and I'm also co-author of Medical Marijuana, Dr. Kogan's Evidence-Based Guide to the Health Benefits of Cannabis and CBD.
And I'm your co host, Janette Rodriguez, the office's administrative director. Today, we're going to have a discussion about a new study that is going to be published in an upcoming issue of JAMA. And this study concerns medical cannabis and the need to standardize the education that we're providing to health professionals. We have three of the article's co-authors with us here today. That includes our own Dr. Misha Kogan. And joining us will be Dr. Ethan Russo and Dr. Leslie Mendoza Temple. Dr. Russo is a neurologist, preeminent psychopharmacology researcher, founder of and CEO of Credo Science, and he's a renowned global expert on this topic. Dr. Russo is an author of some of the most influential and scientifically important books and research within the field of medical cannabis. He has been actively researching medical cannabis and cannabinoids for nearly 30 years, y'all. It's a long time. Also, here with us is his co author, Dr. Leslie Mendoza Temple. Dr. Leslie Mendoza Temple is the chair of the Medical Cannabis Advisory Board for the Illinois Department of Public Health. She is the Owen L. Kuhn Chair of Integrative Medicine, medical director of the Integrative Medicine Program at Endeavor Health, and a clinical professor of family medicine at the University of Chicago Pritzker School of Medicine. Okay, welcome to the podcast, Ethan and Leslie.
It's wonderful to have you guys with us. Yeah, important topic. I guess let's start with very, very basic things. We know that cannabis has been legalized in more than 50% of United States states by now. And of course, those states that have legalized, there are a lot of different clinicians that are recommending cannabis. But, as we know, we have not been universally teaching this topic in medical schools and other health alliance professions. We decided we're going to do this research. So let's open up with the basics. Like, why is this so important for the what's called competencies or for standardized education on this topic? And, you guys can go in no particular order.
Leslie, why don't you begin?
Okay, I was waiting for you. As an educator of our future clinical family medicine physicians, I have medical students and residents that come through where when I have been certifying my patients for cannabis and giving them the education they need to get started, the student or resident often says, this is the only time I've ever heard this level of in-depth conversation with our patients. We really need to have more of my attendings to teach us about these principles. And I believe that this is probably the only experience they're going to get because the comfort level with clinicians on cannabis varies greatly. And I would say at this point, you just don't have that many people who are doing this kind of active work with their patients. And that also tells me that if they're not seeing it in the clinic, they're definitely not getting any probably very significant curriculum in med school. When they're sitting in class and having to take tests, learn the material. And I know, having been a professor at the med school, you have to have a very specific set of guidelines on how you teach a certain subject. And setting out curriculum standards is a very fundamental thing in medical education, residency as well. And no one's done it before. We need to establish a high bar on how we educate our future physicians, nurses, pharmacists, social workers, everyone on how to talk about cannabis in a very balanced way.
Mm-hmm. And Ethan?
Yes. Well, I went to medical school in the mid 70s. Then the only instruction on cannabis would have been as a drug of abuse as part of what was perhaps a 2-hour elective on drugs of abuse. I believe I went to the library instead. And really, the situation is not a lot different 50 years later because a medical student who's interested in this topic, she or he would need to do it on their own. If I might relate a story, about 10 years ago, I was asked to speak at a conference, and a young physician approached me and asked if I would mentor her about clinical use of cannabis. And I laughed, and she quite rightly seemed offended that uh, I had this reaction, but I had to explain, do you understand how unusual it is for me to run into a young physician who's interested in this topic? And that was reflected in the paper because, in fact, about half the people on the panel who were considered experts were over 60 years of age. And I'm definitely on the high side of that figure. So it is a very tough situation right now. I have spoken to uh, medical school deans, and the issue for them is always, so you want to introduce this new piece of the curriculum. What are we going to take out to make room for it? Well, that is an excuse and it has validity. Um, but let's understand something in context. Let's forget about cannabis for a minute and talk about the endocannabinoid system and its importance. It explains why cannabis works. But in medical school, we study the brain, its physiology, its neuroanatomy. Figure this, there are more cannabinoid receptors in the brain than there are for all the other neurotransmitters put together. The endocannabinoid system is a master homeostatic regulator of physiology. It doesn't matter what bodily function we're discussing, it has a role. Now, why would that not be important? So what we're talking about here is not just a problem with a dearth of education about cannabis. There is absolutely the same dearth of education about the endocannabinoid system, and that part is inexcusable, in my opinion.
So I think that was the entire impetus why we decided to do this. We said, look, the only way that education is going to move is if we introduce a required component, right? And so that's when Leslie and I got together. I mean, now this was what, 5 years ago? This was a long time ago. And we kind of said, well, how can we do this? And so this whole idea of saying, look, competencies is how we get things done in medical curriculum, right? So then our next step was to get money, and we got small grant, and then we had Yuval Zolotov, who's in Israel right now, so we can't really easily interview him this way, or we can, but it would be a little challenging time wise, and he took on to kind of organize this Delphi process. And I just want to say real brief, so we don't have to come back to that. So the Delphi is a standard way of researching educational fields. So it's a pretty standardized, what's called modified Delphi consensus process, where we got 20 plus experts. Of course, 3 of us are here today, but there were many other people. There were not just physicians. We had the nurses, and we had a very important critic that I hope Les is going to mention. We had people who were like an emergency physician. We had several nurses, actually. We had some consumer group presence. We had even industry presence. So we got very large variable group of experts, not just clinicians, because we felt that it's critical that the representation is very broad, right? So that no voice is left outside. And then we created this process where we multiple rounds were saying, look, what are the most important things they have to learn? And then we organized them in sessions, which of course we're going to present to all of you in a couple of minutes as we're doing this podcast. And then the result of this is just got accepted to JAMA. We're doing this recording a little bit ahead, which is fine. And we're going to release this recording when the article comes out. So let's go to the next. So Ethan, you kind of opened up with the next natural topic. So I think critical value of understanding of endocannabinoid system. Forget the exogenous cannabinoids for a second. There's this whole large body function. Then often, sometimes I talk to some students and patients, and they have no idea what I'm talking about. when I say, well, your system doesn't make enough cannabis, and they're like, what? What did he just say? So it's kind of amazing. Everybody knows about endorphins, right? Everybody knows about all kinds of hormones, but not everybody knows. So a big chunk of the Delphi process is about that. What for both of you, what do you think in terms of endocannabinoids? What is the most important pieces that every healthcare practitioner has to know, and which we kind of reflected in the study?
Well, I think I would put it in terms of endocannabinoid tone. So this is the idea that the endocannabinoid system has three components. They're the receptors where the endogenous cannabinoids, endocannabinoids, the cannabinoid substances within our bodies that act analogously to THC, um, where they reside, and they are pretty ubiquitous, especially in the brain. Um, and then there are the enzymes that make and break down the endocannabinoids. So endocannabinoid tone is not something we can easily measure. You can't put a meter on somebody's forehead and know what it's about. But if someone is depressed and has chronic pain and manifests certain disorders, especially of digestion, it may be a good bet that their endocannabinoid system is underactive, what I've called clinical endocannabinoid deficiency disorders. Um, and we know that in this situation, that people that have these kinds of problems, particularly when they have multiples of these kinds of problems, that they may find benefit using cannabis. But there are other approaches to it too that include diet, anti-inflammatory diet, prebiotics, probiotics, aerobic exercise. And so I really see this as part of a holistic approach to treating people, to try and get that tone back where it needs to be so that it is better balancing our physiological processes, and that equates to better health.
I think of the, I'm not sure if you came up with this adage, Ethan, or where I read, if you boil down the endocannabinoid system into what it does for us, relax, eat, sleep, protect ourselves from infections from an immune standpoint, and forget pain so you can deal with it better. All of these functions are day to day, moment to moment. Like 5 o'clock, I care about eating, but at 11 o'clock, I care about sleeping. And when you frame things in the endocannabinoid system, you think about everything much more comprehensively. And if you don't have that basic knowledge in medical school, and the substances that people use to influence those activities, like taking an edible at night to sleep, or a patient with cancer taking cannabis so that they'll eat and they'll stop throwing up. If you don't understand the endocannabinoid system that well, you're falling short in what you know as a physician. And we've had to learn the nervous system in terms of parasympathetic tone and sympathetic tone. We've had to learn about the opioid system, or in terms of how they work with medications. Why would you leave out the endocannabinoid system? Because cannabis is involved and it's illegal. It's just been like completely put in the shadows, and we need to bring it out into the light so we can understand there's a difference between the cannabinoids you make, the cannabinoids you eat and smoke, and then the medications that might, that are also being derived from research looking into all of this. So it's very, very basic. I think that students need to know this system. And then as we march forward with the Delphi, we get into a lot more, but I'll hopefully we answered that question for you, Misha, regarding the importance of the endocannabinoid system.
Yeah, well, and and it's also, this was our first competency. So the whole process took several rounds, and we in the end end up with the 6 critical competencies, which we all agreed going to be something that every graduating medical student from Canada, Canadian, and US schools have to know. And so the first one we just mentioned, this is the understanding the basics of endocannabinoid system. The second was describe the main components of the cannabis plant and their biological effects. The third, review the legal and regulatory landscape of cannabis in US. The fourth, describe the evidence base for health conditions that are commonly managed with cannabis. And then the fifth, understand the potential risks of medical cannabis use. And the last one, the sixth, understand the basic clinical management with medical cannabis. So let's kind of divide and conquer. Let's each one of us talk a little bit about, we covered one, let's cover the other five. So maybe start with you, Leslie. Legal and regulatory landscape, why this topic ended up in there? What do you think it's so important for students to know that?
It's because if you're located in Kentucky versus California and your patient's using cannabis, but they're in Kentucky and it's not legal, I believe it's not legal there yet, at least recreationally. If you're in a state where you don't even know what you're allowed to do, that's very basic. You should know your local regulations because your patient in front of you is going to either be asking you a ton of questions about it and you don't want to be clueless about what's legal or not in your state. This is changing constantly. So the other part of our write-up in the journal is that every school that takes upon this framework of 6 competencies, they're going to have to tailor it to what works for their institution. So the curriculum in California at UCLA is going to be different than one at the University of Wisconsin-Madison, where in Wisconsin it's still illegal. So they may not spend as much time on the legal framework because it's just not really there yet. Whereas in California, you should learn how, what are the requirements to get licensure, to write a certification for your patient, because you're going to be doing it in the clinic. So that's why it's important that we keep up with it. The other part too is it's changing all the time. I'm having trouble even keeping track of what's going on federally as everything is like yo-yoing back and forth. There's a new head of the DEA. We don't know if this is going to be rescheduled from Schedule 1 to Schedule 3. There's so much discussion around it. So an awareness is what we wanted to generate, that you have to know what's going on with policy. It's not just a substance with a lot of interesting components that we just break down like little scientists and labs and try it on people. You also have to know the socio-political aspects of it. And that's why the regulation piece is important.
Ethan, you've always been big on the fact that, cannabis is following the standard traditional path, randomized controlled trial, showing what condition it works for, implement, nothing any different. So that the topic number 4, describe the evidence based for health conditions that are commonly managed with cannabis. I mean, some people would argue the evidence for that is very mixed. How do you address this? Why do you think some of these critics maybe not seeing things in the right way, but we decided this was one of the most important topics for medical students. So talk a little bit about that.
Do that one, Ethan, or?
Yeah, this for Ethan.
Okay, sure. Well, again, the evidence is mixed, but let's go a little bit historically. Marinol, synthetic THC, and an analog, Nabilone, were approved by the FDA in 1985 for nausea associated with chemotherapy. That's well established in the literature, and many people smoke cannabis before their chemotherapy to allay nausea and vomiting. Then again, subsequently, Marinol, the synthetic THC, was also approved for AIDS wasting in 1992. There have been various studies that have shown benefit of cannabis on chronic pain, especially neuropathic pain. Additionally, isolated cannabidiol as Epidiolex has been approved by the FDA for treatment of some rare seizure syndromes, epileptic syndromes, including Lennox-Gastaut syndrome, Dravet syndrome, and seizures associated with tuberous sclerosis. Those are absolutely clear. And then there's a lot of support for many other indications. For example, Sativex, which is a natural extract of cannabis. Full disclosure, I worked for GW Pharmaceuticals that developed that and Epidiolex. Sativex is approved in 30 countries outside the US for treatment of spasticity associated with multiple sclerosis. and then their opinions about many other areas. One of the critiques of cannabis, or a critique I've heard people say to me is, people will say, well, you think it's good for everything. And I'll say, well, not quite, but it does help with many different conditions. And the reason is because cannabis is working on the endocannabinoid system, which is everywhere and has a role in almost any disease process you might imagine.
Well, so I think that's the critical aspect. I think part of why we left some of this language maybe somewhat a little vague, because we know that the evidence will change. We know that this whole field is like, it's like still in not even in teenager states. It's like just coming out of the toddler, right? You're just gradually moving towards, pre-adolescence. So there's still so much happening, and there's going to be continuously lots of changes. So I think making sure that medical school curriculum have a room to take whatever they want out of this. So if one school just wants to talk about Epidiolex and Marinol, okay, well, that's their right. And then maybe other schools want. So, we wanted to leave that wide open. But I love that you brought up the whole point. There's several FDA approved cannabinoids. They're widely used, and yet it's not actually widely known. In general public, not a lot of people understand that. In medical community, of course, everybody knows what these drugs are, but nobody wants to talk much about them. It's often the information that students are learning about these drugs are in a very random format. They learn about this in some different side lectures, or maybe in neurology, they learn in pediatric neurology, they learn about Epidiolex. But
Right, if that. But,
if that, exactly.
I deal with many basic scientists around the world, and question I often ask them is, so you're in the Department of Pharmacology, but in association with the medical school XYZ, have you're an absolute expert on this topic, this aspect of the endocannabinoid system, or cannabis as a drug of abuse. Have you ever been asked to lecture to the medical students? And I'd say 9 times out of 10, the answer is no. So certainly these institutions are not availing themselves of the expertise at hand, because we're not the only ones on this panel that know about this topic. We really are not.
There is a lot of competition for medical student time. It is really focused a lot on what they're going to be tested on later on. So we have a heavy pharmacologic knowledge base, pharmaceuticals, that is all going to be well covered on an exam, but even getting nutrition on some tests, it just isn't, it never started off that way. And to try and get space on that very preciously crowded platform of medical student attention, if it's not on the test, they don't want, I don't want to study it, I need to study a million other things. So if you're going to put it on the test, yeah, let's put it, give devoted time in the curriculum. And we had to develop the curriculum first before we can even make the case.
Sure.
So
we need to get it on the
test from a
test.
practical standpoint. Yeah, that's really where you're
first
gonna
you need to
see a
get the
lot more
space,
traction.
That's right.
Right.
and then they can put it on the test. And all I can say is good luck on that, because
Yeah.
from my experience when it comes to nutrition, even though most chronic illnesses today, many of them are preventable uh, because of our diet, not having much luck with that.
Well, it's a long, windy road for sure. I think, just I want to talk a little bit about some of the unpleasantries here. So we did submit this paper first to academic medicine. And I'm going to just be frank. They held our paper for more than 6 months. They preliminary accepted it. They had 4 or 5 rounds on review. And at the end, they just basically rejected it with no additional explanation. So I think because they know that what we're going to do with this paper, we're going to take this paper and we're going to go to the basically a body of accreditation for all the medical schools, to ACGME, and we're going to say, look, it's not our job. This is important. This is what the country is saying. This is what researchers in this field is saying. We know that this is a critical topic. Now you got to figure this out. You have to take and you got to give this to the schools. You have to mandate these competencies are followed. And if you don't, there's going to be a gradual political pressure on you. And I hope that sort of this is a first step. I mean, I'm realistic, right? We're going to be more than 10 years out of from that happening, but eventually I think it will happen. I think it's not if, it's when. That's my hope, at least.
Right. And the thing I would say too, there'd be certain physicians or medical students who really aren't interested in this area of medicine and or are uncomfortable with it. I say fine. But the fact is, your patients are using this. And so if you're going to be doing your job effectively, you still need to know about it, even if you don't want to play in that sandbox.
Mhm. Les, you're in family medicine. You have the widest experience amongst three of us with all kinds of things. You use it for so many different things. And you're teaching it to a lot of, I know you have a residency program that you're heavily involved with. What have you seen on a residence level? Because, students are students, right? They're like, they still have no idea what they're doing with their life. Versus residents already sort of like, well, they still don't know what they're doing, but they're sort of one step closer to knowing that. What
Right.
what are you seeing at the residence level?
I think because of the generation, there's just a lot more acceptance, no shock, no surprise that this is something that should be discussed with your patients. It's the how to do it. That
Mhm.
part is where the residents seem fuzzy on. And if I'm the only attending they've met that's open to this, then I'm seeing more just they're excited just to hear it somewhere. So we need more physicians to be able to spread this knowledge, but that's only going to come with comfort level of seeing lots of patients. I have certified around 1,500 patients since 2015 when the Illinois program opened its doors to this. Of that group, only half of them actually got their license. I certify, but who actually pulled the trigger and got their paperwork done on a computer, paid their fees? About 720 patients I have actively certified with me. So cannabis is like a constant conversation in our visits, along with nutrition and stress management. So it's a piece of it. And the residents I just see them writing everything down and learning the basic principles. So there's an openness, there's a hunger for this, including with our colleagues who you've met, at consortium. They say, hey, they're writing down what do you teach them for curriculum? What are the 6 points? And our hope with our involvement here with our consortium of academic consortium for integrative medicine and health is to disseminate this amongst our faculty colleagues so that they can propose this to their institutions as well.
Mhm.
It's going to be a multi-centric campaign. You have the JAMA article that has the framework published in a prestigious journal with a lot of experts who weighed in. Then you've got people on the ground who are in the institutions who actually could start proposing this to their faculty chairs and saying, let's have a course or a mini course. And you start to see this dissemination of the idea taking root more and more. And that is probably going to be a slow process. But the good news is that we have a generation of physicians, I believe, that are very interested in this. They're open. It just cannabis doesn't have that same really foul stigma it had in the 80s. People are a lot more open to the idea of this as a medicine. On the flip side, what I don't like is when it becomes a free for all of cannabis has no side effects, or that it quotes that it's not addictive, which is not true. It can be. There's the extreme of let's put cannabis in the water, and then you've got the other extreme of reefer madness. And that truth is usually in the middle, and that's where I think we are trying to expose cannabis for what it is. It's good and bad. It just depends on what situation you're in.
So true.
So, what are the side effects and risks of cannabis?
Well, we do have in one of the competencies, because I know we got kind of started on talking about this, that's competency number 5. So understand the potential risks of medical cannabis use. And what's interesting about the Delphi process, when we went through these rounds over and over again, every single word, every choice, even the down to just the word the and of, we picked apart every single iteration of how you say competency number 5. So these were not just casually thrown out. We would have debates over, no, let's talk about it differently, but understand the potential risks of medical cannabis use is its whole topic. So what they are, standard feelings of intoxication, dry eyes, dry mouth, palpitations. Some people can feel more nauseous and sick on it. You could get cannabis hyperemesis syndrome. One of the co-authors on the paper is an emergency room physician, so they're seeing that a lot more in the ER. The only way to figure that out is stop using cannabis. My goodness, I can go on and on about the side effects, but there is a potential risk for addiction, definitely impaired driving. Memory is not so great while under the influence. There's all kinds of potential risks to the young developing brain. There's controversy about what age that is, but that would be an entire course right there. But I hope I explained the answer to that a little bit, Janet, and also in the context of our competencies, that this is the part where the balance comes in, that we're trying to expose all of the good, bad, ugly of cannabis to the healthcare professionals that need to know this first. And one thing that has always bothered me is when a patient knows more about the topic than you do as a physician, and this is all about health. So it's embarrassing to not be a content expert on something that is really should be so basic. And that's why we need to start with these competencies. I know we're selling it really hard, aren't we?
Well,
Yeah.
Leslie,
But we all know that patients out there are using it.
That's right.
Yeah.
Leslie, but I think that's currently one of the reasons why so many physicians are so reluctant to get into this, because they have to feel this level of, oh my God, patient knows way more than I do. And it's definitely not a place where clinicians are comfortable in, right? Like the patient comes in and say this, and that, and you're like, oh my God, I don't understand anything. It's a challenging. I think we're breaking through a wall that, as Ethan said, has been historic here and very heavy. And I don't know, Ethan, you're the best person to talk about this. You've seen this wall gradually getting thinner, but I mean,
Oh, it's still there.
it's still there, right? I mean, at some point it should fall down like a Berlin Wall, but like, where are we in that process? I mean, how much?
Well, I'm afraid it's one patient, one physician at a time.
Yeah.
Back in the 90s, when I was still in practice and discussing cannabis therapeutics with my patients, at first, this is in Montana, no less, my colleagues were aghast. However, when they saw people getting better, eventually they became more accepting, and a few even sent patients to me in this regard. But again, that's like 30 years ago. So it's a slow evolution. I'm afraid on the political level that people only come around to this when they themselves or someone in their family unfortunately has cancer and they've seen them use cannabis to treat pain, to allow them to complete their course of chemotherapy or whatever it is. And that's what causes a conversion to say, maybe this does have therapeutic use and it's not just reefer madness, scourge of the earth. And it's really unfortunate that that's what it takes.
Full disclosure, I do have a Reefer Madness poster magnet pin on my refrigerator that I've had for decades. Um,
Sure. Well,
one question.
I'm sorry.
No, go ahead.
Um, People have to understand side effects of cannabis largely revolve around THC. THC is like a double-edged sword. It can be extremely therapeutic. When there's too much, then there are problems. However, those problems are easily avoidable, either by proper dosing or ensuring that there are plenty of other cannabis components in there to buffer the adverse events associated with THC. So again, this has to do with education. It also has to do with regulation. Can we know what's in every cannabis preparation with a certificate of analysis? and making that available to consumers so that they can actually scrutinize things and have an idea of what they're getting. That's a bare minimum. That's got to be a requirement of any kind of regulatory scheme.
It's
So,
cannabis is messy. That's the it. That's also what makes it less appealing when you're used to pharmaceuticals with single agent mechanism of action. You can boil it down to a very simple chart, but when you look at then just the infinite combinations of cannabinoids, flavonoids, terpenes, everything, different routes. It's I don't even know if you can
different
agree on
soil.
soils where it's grown in one state's different than another, same cultivar, different farm, and it's so messy. And even within patient to patient, I can give two patients the same formula, same dose, and they're like really different reactions. So I mean, I dread it when patients I've seen like 700 plus patients all have different ways of approaching cannabis. They work differently. I have some who are they think it's the miracle in their lives. It solved all their problems. I have others that by this point they feel like they sleep better, but it didn't take away the pain. I have others who had terrible reactions. They'll never touch it again. I have others who just use topicals. They think it works. I don't know. I mean, it's, now that the honeymoon of getting the certification is over and they found that they have access now and they're really evaluating this compared to their other medications and their treatments, it's an adjunct. I have those few patients so that like if you took the cannabis away from them, they would be severely limited in their ability to function. But it's like to me has become like many other things, another tool in the toolkit. But you can
So,
Absolutely.
say,
where can people find these tools? What resources are there out there for healthcare workers who are interested in incorporating this therapy into their treatments that they offer their patients?
you stole my thunder there, Misha. I was going to talk about Dr. Kogan's book that I refer my patients to all the time because if your doctor, which we are learning, may not necessarily be the fountain of knowledge on all of this, I refer them to books like Dr. Kogan's to get a good layperson understanding of what are you putting in your body, the different forms. So you really have to read on your own as a consumer. And there is also a lot of junk out there. Like you go on the internet, there may be big fat claims that haven't really panned out as true. There are also some valuable tools like how to cook some cannabis into a brownie. I mean, there's recipes or stuff, but there isn't one compendium where it's all there. But for medical students, there is nothing until this paper. So from the person who needs to, at a consumer level or physician level, needs some advice, they need frameworks like what is in Dr. Kogan's book. There are other great references out there. But
Are
at
there
some,
any websites that you all could give us?
yeah,
Sure, if I may put in a personal plug, ethanrusso.org is my personal website. I have some 70 articles I've published over the years on cannabis and the endocannabinoid system. Also on the page, we recently completed an educational platform on cannabis pharmacology and therapeutics. It's 40 hours of material um, that I'm pleased to say closely adheres to the goals that were expressed in the paper. So there are things out there. There are other university courses that are being developed. So there are resources. That doesn't mean they're going to be accessible to everyone. The ethanrusso.org website at the library is free to anyone. Because it's my personal website, there are no issues with copyright. People can download and print the articles. So I hope that that'll be useful to people who are interested in getting more education about these topics.
before I met Ethan here, I actually referenced a ton of your stuff in my lectures as I was gathering my stuff. One of my favorite pieces of your work was the buzzkill, the list of terpenoids that could potentially offset the side effects of cannabis, like pine nuts, pistachios, anything citrus. That that is, I'm just going to endorse Ethan before he even knew he was this well known. I was already using your stuff.
Of course,
So,
and I'm reusing Leslie's slides in half of my talks, so that means that
okay, it's a small world. And when we, I know we're kind of getting off topic a little, but when we were putting together the Delphi, because Misha, myself, Dr. Zolotov, and Dr. Richard Israelowitz from Ben Gurion University, and Dr. Zolotov is from Albert Einstein. We know it's a small world in the field of cannabis in terms of people who have the best reputations on education, research, and advocacy. And we reached out to who we know, because that's kind of when you're starting something from scratch. We couldn't invite everybody. There's a lot of names that are not on this list of authors that would be like, why wasn't I included? It's just at some point we also needed a balanced group of naysayers as well, people who are not looking at cannabis as a therapeutic option. One of them being my friend and colleague, Dr. Gerald Lycan, who's a toxicologist, who I am actually debating at the North American Clinical Conference for Toxicology, Congress for Toxicology in Chicago in late September on the pros and cons of THC. So we are going to talk about cannabis from a therapeutic. Clinician uses it to help her patient's perspective, and his perspective is, I got paged at the ER for another cannabis hyperemesis syndrome patient, or the kid who ingested too many edibles at the concert. He sees the downside, I see the upside. I actually see both, but we're going to be talking about this. He was part of the Delphi process because we wanted to make sure we didn't just have a group of people who are only supportive of this idea. And that is how this is why I think the article was successful in its acceptance, because it's as balanced as possible about pros and cons. I wanted to come back to other resources now that I've thought about it more, but the Society for Clinical
Cannabis clinicians.
Yes, yes, that is a really great. They've got all these ready-made modules for healthcare professionals to dive into. You can do a module at a time. They're really deep. There's only so much you can do a day, but for the patient, looking at how am I I'm at the dispensary. What do I get other than talking to the cannabis associate or bud tender, as they're called, reading ahead of time, something like Dr. Russo's or Dr. Kogan's books are really key. I also give general rules of thumb that if you're going to start with anything, start with the lowest amount of THC and let that drive your dose.
That's what I hear Misha say all the time.
It's like, it's probably the easiest thing you could ever tell someone. Just 1.25 to 2.5 mgs as your first ever dose of cannabis in whatever amount that is, unless you're smoking or vaping it, which is very hard to tell how much you're getting. Tiny sips, small, and then wait like 2 hours, see what happens. Nothing happens, you could redose. So all this practical knowledge has been gained from learning from our patients, telling us the hard way how they learn. So your question, Janet, is great, but there's still, like, even if you have all the greatest books in the world, you still have to try it and see how you feel in a very graded and gradual fashion.
So we're getting close to finish. So let's just do final thoughts. Let's start, Ethan. Let's start with you. Your last final thought.
Well, I hope that this paper will serve as an impetus to get cannabis and the endocannabinoid system into medical school curricula. I'd like to see this part of an effort politically to get certifying bodies involved, politicians involved. I hope it'll be a catalyst to change.
Thank you. And Leslie?
I think that this is going to formalize a part of medical education that has been very ad hoc and random, depending on your institution. We need more standardization in terms of the education piece by offering a framework from which schools can tailor make a curriculum that they're comfortable with. We're not looking to ram cannabis down people's throats and make them believe in it and such, but you have to have an educated medical workforce. And we are very, very behind because the policy and the social public use is so way ahead of how we usually promote or get drugs to pass through the process. It's an unusual place to be that we're now playing catch up on the education. But so we're doing catch up with this, and I think it's going to be very helpful. Also, I don't know, Misha, I know we're running out of time, but there was another component of the competency number 3 was to review the history and policy of cannabis in the U.S. and implications for medical practice. And this is talking about a lot of the socio-political things that I will say will be probably very different from institution to institution. But we didn't want to ignore all of the rough beginnings that cannabis has had, the implications and racial matters that have come about and made it just such a very storied substance that we need our healthcare professionals to understand. When I compare this with alcohol and how that just got through, bootlegging and prohibition, and why is alcohol, which I think is a much more dangerous substance, is fully incorporated in society, advertised about, it's glamorized, and here we are putting a microscope on cannabis. So let's be fair about all the other substances that we have that are available in society that can cause harm or possibly good.
Absolutely. Well, yeah, we did. I don't think we had time to touch up on every little piece of the paper. So we'll make sure that readers and listeners will have an access. So our paper is coming out in a JAMA open access. So we'll make sure that everybody can read the full article if they choose to. Of course, we're going to list Dr. Russo's website and some of his resources, and we'll probably list some other things as well. So Ethan, Leslie, thank you so much for coming and talking to us. It was an absolute delight. I'm Dr. Kogan.
And I'm Janette Rodriguez. This has been the GW Integrative Medicine podcast from the GW Office of Integrative Medicine and Health.
Thanks for listening.
Thanks for listening. Bye, y'all.